compression inner ear balance program here at Folsom. So as I developed this program back in 2009, I kept hearing all about, you know, if you really want to maximize your patient's rehab, you should get in touch with a neuro-optometrist. And I got in touch with a few, but they'd be like in Auburn or all the way in Sacramento. And I know, so hard. But the challenge with some of those was that I felt like there also wasn't a ton of vision therapy that accompanied it. So it was like they would go and then I wouldn't hear anything back. So lo and behold, Miss Poonam moves to the area and she says, "Can I come by your clinic?" And I said, "Sure." Right? We had a fantastic conversation. And she has been wonderful because there are times where I have patients that do really well on the vestibular end and on the balance end from getting stronger, but they still feel dizzy and they don't understand why. So she has been such a phenomenal asset to helping kind of round out the rehab my patients get, as well as there's times where I can tell based on conversations we've had, she should be the first stop. So what I realized is there's a lot of people out in the community that have no idea what neuro-optometry actually is, how critical it probably is for a lot of people post-stroke, chronic dizziness, migraine, and especially with the older populations that suffer from a mild concussion. Because when you're a kid or a teenager and you get a concussion, you get all this phenomenal rehab. Once you get over the age of 25 or 30, good luck. So, and then unfortunately, people who are over the age of 65, if they get a concussion, they're told like, well, your dizziness is because you're older, right? And no one really does a really thorough evaluation to say, well, is it age-related or is there actually underlying comorbidities that unfortunately are now becoming harder for the brain to manage because you've had an injury? Mm-hmm. So I asked Dr. Nathu if she could speak on this topic because I feel that she has such great passion, not just, not only is she intelligent, but she is very passionate to help all of her patients. I would say that I would hope for any of you guys coming away from this talk that you would also know she does a great job with kids. So if you have kids out there or you know people with kids and they're being told my kid doesn't pay attention in school or their kids are struggling with dizziness, and kids don't know how to talk about dizziness. They'll just say, it doesn't feel good, my eyes feel tired, I can't concentrate. Go see her, because I will tell you a lot of our patients who struggle with vestibular migraine, PPPD, or chronic dizziness probably have underlying visual issues that were never addressed. And then as they aged, they became harder to manage or they had an injury and now it's doing this. If they can get that help early on, it does worlds of difference for helping their brain be more calm if they had any sort of other issue. So I will let you take it away. We're going to hold questions to the end if possible. I realize if you guys don't understand a term, politely raise your hand. But for the most part, we're going to let her go. And then at the end, then we'll take questions. Okay? All right.
Yeah. Thank you. Oh, my God, that's so great. Thank you guys so much for taking the time to come out. And thank you, Brigit, for like spearheading this. She just texted, we were texting back and forth about patients, and she's like, you want to do this? I was like, sure. Let's pick some dates. So I want to give, this talk is really for information. I'm not going to use a lot of lingo. You'll see slides with a lot of terminology and stuff like that. But I want to just give some things that the way I explain things in my exam room and what's going on, more layman's terms. And then I would love for us to have like a dialogue about specific questions or experiences you guys are having that may help everybody else as well. So a little bit of backstory about how my buy-in to my field and why I do what I do. I was born with an eye problem, developmental, my left eye doesn't turn to the left. And when I was 5 years old, they did surgery and they did it on the wrong eye. So they accidentally did it on my right eye. Yeah. So when I was 7 is when I was able to verbalize that I was seeing double all the time. And I was struggling academically, and I had a lot of tutors and stuff like that. And one of my tutors was like, something's going on with how our eyes work together. And so that's kind of how I got into vision therapy. And my trajectory just stayed that way my entire life. My director of my residency program was, and still is, a trailblazer in brain injury. He really thinks outside the box, and he's the one who really helped me understand to, push the walls a little bit and ask the strange questions and really go against status quo. So I love working with this world and the vision and people like Brigit and stuff, because we co-manage so many patients and we go back and forth because we are very tangibly able to make differences in a very quick way sometimes. So anyways, the talk is really about like how does vision play a role in like dizziness, imbalance, feeling a little disoriented, with or without a brain injury. So just to start, like, what is neuro-optometry? I'm going to kind of take a couple of steps back, and the difference between ophthalmology and optometry, because I think we sometimes, even in like the medical field, like some people will just say a term and kind of, it's sometimes not used as properly as they should. Ophthalmology, the only difference between optometry and ophthalmology is ophthalmology is able to do surgery. We as optometrists we can diagnose, treat disease, prescribe all medications, we just don't do surgery. So that's really the big difference between the two. Neuro-optometry and neuro-ophthalmology are also very different. So neuro-ophthalmology is more pathology. So you have a brain injury or some sort of condition or some sort of disease. Neuro-ophthalmology may run scans, may do further testing for diagnosis. That's mainly what neuro-ophthalmology helps with, is ruling out certain conditions or disease for that. Neuro-optometry, we are more the functional world. We look at the function of how the visual system is impacting the patient's daily living, whether it's walking, reading, computer work, whatever that function may be. So that's the big difference there. We don't run the MRIs. I may prescribe one or ask to get one, but most of the time we're not the ones who are, by the time they come see us, all that testing's done and everything's ruled out. So that's kind of the big difference between neuro-optometry and neuro-ophthalmology. So then I like to spend a few minutes talking about the difference between eyesight and vision, because I think there's also a misconception that eye doctors just prescribe glasses. And when you look at primary care optometrists, they rule out a lot of disease and they make sure your eye's healthy on the pathology level, and they also help with making sure your eyesight is good and you're able to see clearly. But vision is a lot more than that. Vision is how your brain and your body move through space and do other functions like read and stuff. So I think I'm going to jump the gun here, but the way I describe it to some of my patients is if you take the visual system on a 100% scale, 20% of that is your sight, how clearly you see, if you're able to read and see the signs when you're driving, which is important, but it's not everything. The other 80% is how your eyes and your brain communicate with your vestibular system, your proprioceptive system, which is like your sense of feeling, where you are, grounding, and your other senses. And I'm gonna kind of break that down, but that's the big difference between eyesight and vision. When we look at the visual system, and you further break it down, we have something called our focal system, which is our center vision. And then we have something called our ambient system, which is our peripheral vision. So focal is, okay, let's just, for having an example, I'm looking at my book, I'm scanning, so that's a skill to be able to scan smoothly instead of jumping around. So you're scanning, you're keeping the image single. Those are focal tasks that your brain have to do. Ambient is how far are you holding that book from your face? How do you feel with, like, are you kind of zoning in, or are you kind of aware of your periphery? That's probably not the best example, but so your focal system is very conscious. It's very, I'm doing something, I'm walking towards something, I'm going. Your ambient system is not as, is subconscious, but it's super important in terms of your balance and you're feeling safe and calm in like a busy area, feeling grounded and stable when you're walking. Those are ambient skills, and those are processed in different places in the brain. So when we're looking at someone, and we're going to specifically kind of hone in on dizziness, when we're looking at dizziness, where does vision come into that? Because we think of dizziness and we're like, oh, it's vestibular, it's inner ear. But what we're starting to learn is that ambient system, that 20% of input that's going to the brain, it's getting processed with the vestibular input in a specific part of the brain called the midbrain. And that's where your vestibular input comes in, that's where your visual input comes in, and that's where your proprioceptive input comes in. And all those systems communicate in this one little area of the brain. And when you experience dizziness and stuff, something's going on with those systems. And so now it's our job to figure out which one is kind of leading that. The reason vision kind of gets a little bit put to the side is because we don't really think of it as an integral, well, I should say some people don't think of it as an integral part of those three systems, but it's huge. It's one of the, along with the vestibular input, it's one of the top 3 sensory inputs that your brain gets. And sensory input is information. That's how our brain gets information of where you are, what you're doing, and things like that. So yeah. This is a picture my residency director drew, and I'm not gonna go too much into like what it means and stuff, but the reason I like to kind of have this is because it shows that so many parts of the brain are responsible for visual processing and visual input. And so if you have a stroke or you have a fall and you kind of, even though you're not technically diagnosed with a concussion, the brain is like very sensitive tissue, you know? And so like if you get punched really hard I tell this to people all the time, if you get punched really hard in the arm, yeah, you're not gonna break your arm. You may not even bruise. Some people do, some people don't, but you'll be sore. And so when you have your brain super delicate, and if you have some sort of impact or a jolt of some sort, you don't know how it's gonna affect you. And so one of the things I ask and I kind of really peel away the layers to is when I have a patient that comes in, and sometimes dizziness and some of these symptoms are spontaneous, but sometimes there could be an underlying something happened maybe a couple years ago, or maybe back when, 20, 30 years ago, maybe they were a football player, which I just had a patient that had these really bad symptoms, and I was like, you've never had a concussion, nothing? And he's like, well, I was a football player in college. I'm like, okay, well, you probably had a couple concussions there. So this image really, it has a lot more, there's a lot more to it, but your takeaway would be that there's a lot of parts of the system that are integral for the visual system. I'm going to skip this one. So what are like the most common things that I hear day to day? So someone says, I feel, and we can have it, I do want to talk about the difference between feeling dizzy and disoriented, because there's also a difference there that I don't feel like we always really talk about. But dizziness is like, is the room spinning? Or do you feel like you're spinning? Versus disorientation, do you feel like you're kind of like walking on a waterbed or floating or feel dissociated from the world or the floor? I've heard people tell me that, they feel really overwhelmed in busy areas. That's a super common thing. They go to Costco or like the grocery store and they're trying to find a can or find a vegetable or something, and it's just like so disorienting because there's just so many options. So we're going to go through why that's the thing. Poor coordination, not just, there's coordination is multifactorial as well. You have your physical strength. If some people have strokes, they have maybe weakness on one side or one part of their body versus the other. So does that affect the coordination, or is it truly you feel like some people feel like they're swaying to one side when they're walking, or they don't have any misbalance in their muscular system, but they still feel like, I just don't know, I feel like Bambi, like I don't know how to walk, Those are some of the things that we get. Or navigating their space. Recently I've heard a lot of like just kind of I've been going to the grocery store and their house. I've been putting things in the same place over and over again. I just can't seem to figure out how to get to it. How do I get to that cabinet, or how do I get there? Where do I put this? And organizing certain things in their space. That's been something that's come up too. So those are common visual, those are symptoms that could be related to the visual system. And so I have, we don't have to talk about all of these, but the top category, are some things that we kind of use as diagnoses. There's something called visual motor sensitivity. Maybe you're driving and you're okay, but seeing like cars drive by you is really triggering. That's visual motor sensitivity. Or just like things moving really fast in your periphery. That's what that means. Visual midline shift is when your brain perceives your center of gravity shifted to the left, to the right, higher, lower. It's not in the center anymore. And that can happen many different ways. But that's essentially a survival mechanism for your brain to, again, get you through space, but you're shifted a little bit. Binocular vision dysfunction is a big term. It's a big umbrella term, is what I say. It essentially means that your eyes are not working together as they should, like a team. It's kind of like, and I use this a lot in the office too, is like you're wearing a stiletto high heel in one foot and like a really comfortable tennis shoe in one foot. And so you start your day and you're okay. And then like throughout the day, you get calf cramps and your hips are hurting and you're just like, the symptoms start to like move up. And so patients that have binocular vision dysfunction maybe start okay in the morning. And then they start getting a little bit more disoriented, dizzy, headaches, nauseous, tired throughout the day. So they just fatigue over time. Ocular motor dysfunction is just tracking. So there's a lot of different categories to that, but essentially tracking. When you're reading, are you able to read smoothly, or are we jumping around a little bit? If you're at the grocery store and you're looking for something in the grocery, are you able to scan properly? Or we feel like, oh my gosh, like there's too many, like where do I look? And you're just kind of jumping around. So that's what ocular motor dysfunction means. And then light sensitivity. Light sensitivity is very common. It's also, we consider it a very deep symptom. It's a trigger. It's a trigger for our brain. That light, whether it's, all the different types of fancy lights that we have these days, it creates stress for our system, and so that can show up as pain, disorientation, mainly those two things. So Those are some of the things that come with someone that has vision problems. So how many of you guys have heard of prisms? I know that's like a great. So prisms are a tool that we use. Everybody prescribes prisms very differently. It's definitely an art to prescribe them, but at fundamental level, it's just a lens. It's a lens that shifts light. And so there's two big ways to use prisms. There's something called compensatory, which means that if you have a deviation of some sort, say your eyes are misaligned on the horizontal plane or even on the vertical plane, we can use prism to help bring that into alignment at a certain degree, okay? If it's like the deviation's way too much, prisms don't work. But if that's a compensatory way. We have a misalignment, we're trying to align the eyes. A yoked, which is a more therapeutic way of prescribing prism, is to manipulate space. And that's the big difference, because yoked prism or therapeutic prism is not, it's not a crutch. It's essentially, we're going to be showing your brain a different reality, shifting how your brain currently perceives information coming from your world. And then the theory or the intention behind it is that it's going to start communicating with all your systems very differently because it's new information. It's presented in a new, different way. And so then your brain starts to adapt to that and adjust. And eventually those prisms are useless. And that's when you know that you're done and you don't need them. And so that's called those are therapeutic. So prisms, again, are a wonderful tool for us because we're able to make significant change in a short amount of time, but there's a variety of different outcomes to that, and it's unfortunately it's very dependent on each person. And then there's something called vision therapy, and vision therapy is essentially like physical therapy for the eyes and the brain. So it's an active form of therapy that we're pushing the system to work at a, well, it depends on what we're trying to achieve, but essentially work more adequately, functionally, with more stamina. And I also don't think vision therapy is right for everybody, because if I have someone that's very symptomatic and I throw them into vision therapy, they absolutely hate us. Like it's super painful and uncomfortable and symptom provoking. And so we try to get a lot of relief with prisms first to calm their systems down before we throw someone into vision therapy. But vision therapy has been very successful with people trying to achieve higher function that glasses only give you so much, right? So. So what is, or what do we do during vision therapy? These are some of the things that specifically that we work on, and I'm going to kind of rearrange the order of them. But when we're working on when we have a patient that has like dizziness and stuff like that, we always work on that ambient system that we talked about in the beginning, that peripheral vision. We try to line it up a little bit more accurately with the vestibular. And so we work very big picture, and then we work our inward. And so that tracking portion, that's kind of sometimes the last thing that we really hit. But we work on the balance and posture integration with your visual system, your peripheral awareness. And peripheral awareness is not so much just like, oh, okay, I'm looking at this side of the room, and am I aware of them here? Peripheral awareness is, has on a fundamental level has been a safety thing. So how does your brain feel comfortable in space? And if we don't feel safe, then you can have other psychological things come up, like feeling scared or PTSD or anxiety. And that's common later in life because people don't feel safe in their surroundings. And so that's something that we kind of touch on too. These are not my photos. I Googled. I don't have any photos from my clinic, but these are some of the things that, kind of tools. This is called the vectogram. I used to hate this one as a kid. It's really uncomfortable, but we're working on, working, again, your eyes working together on that Z-axis. And then the Brock string, which I think some of you, if you work with Brigit, you guys have used those. And then higher order stuff, right? So someone's standing, we're getting their vestibular system intact, the ball is moving, and then we're asking you to use your eyes to judge space. So just a few examples of what we do. I didn't add this slide, but I'd like to talk about how I assess whether a patient has a visual component in their dizziness or in their imbalance. So going back to that 100% scale, when 20% of it is sight, 40% is that visual skills and visual processing. So collect your eyes collecting the data and your brain processing that information to give it meaning. So if you're reading something, that's comprehension. But are you able to track properly? Are you able to keep it single? Those are our visual skills. And then the second 40%, the last 40%, we call it spatial analysis. Where are you in space compared to everything else? Where's your body in relation to this object, this moving car, whatever? And so when we're looking at that component, that's the most important, and that's where we've gotten the most impact for patients that have dizziness or imbalance. And so when we're evaluating someone, we're doing a lot of different tests, but essentially we're looking at how are your eyes collecting data on the x-axis, on the y-axis, and on the z-axis. And that z-axis is super important. And so what happens there is that the eyes collect that data. A portion of that information goes to our vestibular system, and it tells it, where are you? And then a portion of that goes to the brain, and then the remaining portion goes to the brain, and it tells you where you are, again, in space. If your eyes are not collecting the right information, or I should say the most accurate information, then your inner ear is going to be like, where are you? I have no idea where you are, so I'm just going to pick a spot. And then the brain's going to be like, I have no idea where she is, so I'm going to pick another spot. Because they have to have one point. You can have multiple points. And when those two systems communicate, that's when you feel, whoa, because those numbers don't match. And so it's truly just matching, lining everything up. And so one of the most common tests that I do is I just have someone bend down. A lot of the time I get people say, when I tie my shoes and I stand up, it's like, woof, that whoosh feeling. Or when I turn around, that's because those data points from your visual system are not communicating with your inner ear properly and your brain properly. And so by using PRISM, I find the deficit, I find the imbalance, and then I line it up however I need to, whether it's compensatory or therapeutic. So if sometimes I'll have a tiny bit of misalignment vertically, which the patient's not seeing double, but there are two different points. So, I'm looking at your brain's going to it's going to take two separate points. And so that's one way. So I would use a type of PRISM there. If someone says to you, I never feel like I'm looking at something, I feel like I'm always looking around it. I can't really focus on something. That means that their eyes are not aligned on the z-axis, that there's a little bit of displacement. if I'm looking at like that speaker back there, my eyes should be at the speaker, not like this, right? And so if that happens, then you're getting a lot of spatial misunderstanding of where you are in space, and so that can cause some symptoms too. And so what we do is we use Prism to help bring that into alignment, so now all the systems are more accurate and they're able to communicate with each other better, right? So that was my only plug. So what questions do we have? I'm going to abruptly end it. Yeah.
You're talking about how it seems the eyes and the vision affect things. I maybe was always under the impression like your inner ear and your balance and all that. That is some of the things you're talking about, especially balance or dizziness, maybe would stem from the inner ear.
Totally. Absolutely. So, yeah. Yeah, so the question was essentially, his understanding was that anytime there's like dizzy, and tell me if I'm saying this wrong, if someone has dizziness or imbalance, and it's stemming from the inner ear, right?
Yes.
And so yes, but you have because that's the organ that's mainly responsible for that. But there's portions of other sensory information that's helping this system function the way it should. And so I think one of the first patients we got connected with, I can't remember exactly, but I think what happened was like I did something or you did something and the patient felt worse. So what happens a lot of the time is like if you're having imbalance or something and everybody's like, I'm not sure, like your ear looks great, ENT rules you out. A lot of the time I really rely on Brigit. If I feel like, okay, this is going on with the visual system, but their symptoms are really severe, I will send them to her and I'll be like, can you just rule out any vestibular component here? And if she feels like, yeah, there's some imbalance, some weakness, but not as much as it's like showing up in the symptoms, then the visual system is a component of that. A lot of my patients come to me as a last resort. They've seen so many different doctors, and they're like, everybody's ruled me out. No one can figure out why I have this because everything looks normal. And so that's when no one's really looking at how that visual component comes into play. Does that make sense? Yes.
Yes, when we talked about using the prisms to correct that Z-axis,
Yeah.
is that something then, that's not just temporary, then you grind that into the lens, or you incorporate that into the lens?
So we can write it up where we put it into your lenses and no one really knows you have them. Yeah, it's not very much. It shouldn't be very much. It should be a very small amount. No one should know that you're wearing prisms in your glasses. Yeah. Yes, sir.
I had cataract surgery. My left eye I use for reading, the right eye for distance.
Yeah.
When I want to read, it's 250. Can I get over the counter 250 glasses and read better?
Yeah, let's talk about that.
Huh?
Yeah, let's talk about that a little separately because I have a few questions. Yeah.
So that was, even though I got 250 on this one, this one I get 250. So I get 250 glasses, put them on. Will that help me read better?
It could, yeah. It's worth a try for sure. But when you have that kind of, when you have that differentiation between the two eyes and then you put that much power on top, sometimes you could do great, and then sometimes, but trying it won't do any harm. So if anything, just give it a go and see how you feel. Yeah. Yes.
Do you find that when you're using prisms that you need to continue to strengthen them, like you bring things into alignment, the brain says, oh, okay, but I want it to be this way. So the brain's now compensated, and it gets lazy again, and then you strengthen, and then it gets lazy again, and it comes.
That's a really great question. So the question was essentially when you get Prism, what are the chances of your system getting like lazy and needing more Prism and kind of this vicious cycle? So that's called eating prism. So eating prism is what we call it. Yeah.
I guess my eyes are eating.
Yeah, they're eating. So that happens more in compensatory prescribing. So when someone has a deviation and a doctor prescribes prism to correct that deviation, it's a very small percentage of people, but that is something that can happen, is that they'll come like a month or two later, and whether it's that double vision or whatever the symptoms that were there originally are back. And then they may remeasure and they may say, okay, let's just up it a little bit. And then it becomes like a vicious cycle. So in those situations, again, depending on why they're prescribing that way, prisms are not the most successful, and then you would be a very good candidate for therapy, because then you're actually physically strengthening the system. So yeah. Yeah.
I've been having problems with balance when my head is tilted.
Ah, yeah.
And so I'm thinking that's basically the ear, and the eustachian tube is plugged up sometimes not.
Yeah.
But is it appropriate to think that, or is there something about where I'm looking at the time that I'm tipping or turning or?
Yeah. Yeah, good question. It is appropriate to think that way, because to think that, oh, inner ear, one of the tubes, maybe a crystal, or, that's not inappropriate. But it's also appropriate to not forget about what's like what you said, like what you're looking at, what you're doing with the visual system. So if you do tilt your head, you're essentially misaligning your eyes a little bit. And so if you have a poor ability to fuse the image, that the two eyes see individual images, and your brain is supposed to put those images together, and if you have a lack of strength and ability to fuse them, the brain doesn't like it. It's not very comfortable, and so you could get symptomatic. People get that a lot with like turning like ear to head or ear to shoulder each way, and then also over their shoulder. That can happen too.
And so my feeling is not, I don't call it dizziness because it's not around in circles. It's just not being able to balance myself, hold myself up. I feel like I'll fall. So I'm just trying to distinguish between
Yeah.
all of that.
So I guess my question, or I guess my response to that would be, well, first of all, have you been evaluated for your inner ear?
I'm sorry?
Has someone like taken a look? Yeah, have you seen Brigit?
Oh, yes. I have decent vision. My vision is actually going because of cataracts, and I don't know, that just seems like a shield over your eyes, so I'm not sure that's the same thing.
Yeah.
Oh, can I see you?
No. Have you seen Brigit? That's okay. That's okay.
I haven't seen the Neuro-Optical. I haven't seen anyone for that.
Yeah, so I'd probably start there. I would start there and rule out that first. And if the balance between the two systems or the two sides are even, and you get you know what, everything looks pretty okay, then I would then dig into the vision part or the eyes part. But I would start there, for sure. Yes.
I want to make this simple for people that are, rather than doing individual problems.
No, it's okay.
But you had a little slide up there for a bit that kind of showed you how people progress through getting an evaluation. So, some people may have already seen an audiologist or an ENT person and had a thorough workup, and maybe had an MRI of their brain or neuropsych testing.
Yes, yeah.
And still have a problem. And it sounds like some people here have had little bits and pieces of that done. But in my mind, I want to know the next step. I'm a retired nurse practitioner, so I'm always trying to figure out.
Yeah,
how to
totally.
get people to
For sure.
So.
I think you're talking about
like the
this.
next step after some of these evaluations have been done, like the first level of evaluation, would you see like Brigit for an exam?
Yeah.
And, you know, some therapy, if that was indicated, that she would make a recommendation as to whether, you know, seeing a neuro-optometrist
Yep.
or ophthalmologist would be next, or whether there was a test that wasn't done that needed to be done.
Yeah.
And I think that's what's hard for people to figure out. I tried this, this, and this.
Yeah.
Where do I go now?
Right. So if the question is like where in if you've gotten a lot of tests done, or like when's the right time to see our neuro-optometrist? And there's so many like different ways of going about that. One of them is like, you know, a lot of the testing has been done and no one can really identify where this is coming from. I would give me a shot, or give any neuro-optometrist a shot, frankly. If it's just like, okay, you know, you've had all the tests, you've had all the, you know, everything, and no one can really pinpoint what's going on. That's one category. Another category is if you've seen everyone except a vestibular therapist, I would get evaluated by someone first. Because across the country, neuro-optometry works very closely with vestibular therapy because it's very intertwined. And so it's kind of like you don't really, it's like the chicken, who came first, the chicken or the egg? You don't know who to go to first. There's no right answer and there's no wrong. Who can you get access to? So if you can get access to a vestibular therapist first and they feel like, okay, everything's pretty stable or something, they'll help identify the next step. Okay, you feel you're pretty good here, you should go get checked out here. If you come to us, I do it all the time. I'll be like, okay, this is what I feel is going on, but I don't want to prescribe anything until you get checked out by Brigit first. And so I'll send people to Brigit, and then they'll come back to me. And so there's no right or wrong, and so that's why it's a little hard. But I would say if we're not getting answers by, you know, the ENTs and the scans and even your primary care, a lot of people, if a lot of specialists are not able to pinpoint what's going on, I would say tap into the vestibular world and the neuro-optometry world. Yeah, yeah. I think I saw a hand over there. Yeah. Oh, sorry. Okay. Who'd you point to first? One.
Right.
One.
How much of all these procedures that you're talking about require surgery?
None. Again, we don't do surgery.
How much of all these procedures you've talked about are covered by insurance?
That's a good question. So very little, but that's why I like to co-manage with, I love to co-manage this, and that's why, is because insurance does not cover vision therapy. They don't think it's medically necessary. So in 2023, we actually had some families and some individuals get reimbursed fairly. 2024, it was like a disaster, like something just happened and literally no one got reimbursed. And then 2025, we don't know yet what's happening. So the big answer is that insurance does not support what we do. So when I have someone that comes in that is seeing a physical therapist or seeing an OT or someone, I will co-manage. I will get on the phone and be like, this is what I'm seeing. This is what I prescribe them. But can you do A, B, and C for me? Because I don't want to add vision therapy on top of that. Right? So you can ask to be co-managed with your current care team if you have one. And if you don't, there's also a circle around that. Like I just had a couple that he had a stroke and they did not have a care team in place. They did not have a OT, a speech therapist or a PT after his stroke. And so I was like, let's establish that care team and then I will work with them to get some vision stuff implemented. Who's number two? Two.
Two-part question.
Sure.
One, do we need a referral come to see you from a PCT or something?
No, you don't.
Call and make appointments.
Yeah.
How far out are you scheduling appointments?
Oh, right now I'm like 3-4 weeks out. Yeah. Mm-hmm. 3. Okay.
So my question is photophobia.
Yeah.
I always assume photophobia, from what I've been told, is a symptom of the migraine, but it sounds to me like you're saying there is a.
It could be. It could be, yeah.
Could you elaborate on that a little bit? Like when it is, how you know, can you tell, or?
Yeah. So the question is like, she's a chronic migraine. She experiences migraines chronically. And when do you know if the photophobia, the light sensitivity, is caused by the migraine or is it caused by your visual system? And that's a tough one. So light sensitivity is a symptom during migraines, or can be a symptom during migraines. Light sensitivity should not be a lingering symptom after migraines. So if you do have a migraine, I know I have like a couple people in my care that, they've, sometimes their migraines last 1 or 2 to 4 or 5 days. So it depends on the severity of your migraine. But yeah, if you have it for like 4 days, the migraine, then yeah, you're probably gonna be beaten up a little bit after and you'll have some lingering light sensitivity. But if your migraine lasts anywhere like in a short amount of time, whether it's like a half an hour to a few hours, then no, that lingering light sensitivity should not be there. Light sensitivity is a stress response. It's a I'm really hurting response, like I'm struggling response. And so that's why it's really deep. It's like hard. And I've had people that come to me and I've helped in so many different ways. They have said, okay, I'm 90% better, just fix my light sensitivity. And I'm like, that's really hard. And so we'll try filters, we'll try tints. There's a new thing that we're dabbling with, something called light therapy, to see if we can calm it down a little bit more. But it's hard. That one's tough. Yeah.
So let's go 4.
4 or 5. Yes.
Hi.
Hi.
Does downbeat nystagmus fit into this
Yeah.
situation?
The question was, does downbeat nystagmus? Nystagmus is, for those that don't know, is involuntary eye movements, and they can happen horizontally or vertically. And where did it start from? Was it a stroke or a hemorrhage of the ear? So nystagmus is a really hard one. And so it depends on how much of that temperament you have. We call it temperament. If I'm able to find it's called a null point. If I can find a point along your z-axis that calms your nystagmus down, then we can be a little bit more successful. But sometimes finding that point is really hard.
Okay.
So I don't have an answer for you.
Is there another specialty that would be better at
Nystagmus.
trying to tie that down?
So is it the symptoms that we're trying to die down, or is it the actual nystagmus that we're trying to die down? Is it the symptoms that we want it to treat, or is it the actual nystagmus?
I've got a balance/dizziness.
Okay.
And I'm just trying to tie whether that might be part of the issue.
Yeah. There is a provider that I refer all my complicated cases to. He's an ophthalmologist. He specializes in peds and something called strabismus. He's through the UC Davis system. His name is Dr. Ben. And I'll give you his number, or I'll give you his number and name. His last name is very difficult to say, so everybody calls him Dr. Ben.
I'll check that.
I'll get that number for you. Yeah. Yeah.
Thank you.
Andy, you know what triggers vertigo?
That's a loaded question.
Not too much wine.
The question, yeah. The question is, do you know what triggers vertigo? Do you want to take a stab at that one?
That is a loaded question.
Yeah.
It depends on type of vertigo, so it could be when you experience it. So it could be something as simple as vestibular neuritis. It could be something like PPPD. And then the question is it truly vertigo, or is it what people feel like they're off balance?
Yeah.
It'd be trying to like, you'd have to like.
Rule it out.
You'd have to tease out like
Yeah.
what the actual symptoms are when they're occurring, which the timeline of like, is that minutes to hours? So I would say that would be again, one of those things where you can see her or see me and then try and figure that all out.
And talking about vertigo, I have these intake forms that I ask a lot of questions on just to understand before I see people. And they'll say, yes, I have vertigo. When you actually like have a conversation in the office about like, tell me about your vertigo. Oh, I don't think I have traditional vertigo. I feel more like this. So vertigo is also, I feel like, is a little bit of an umbrella term because there's so many different ways of feeling a certain way. So, sorry, we did not answer your question.
That's okay.
It was complicated. I've
Yeah.
been told I have retinal migraine. Is that
Ocular.
a vision or vestibular issue? And I have a second question.
Okay, it's probably ocular migraine. And ocular migraines are, again, a stress response. So it's a biochemical stress response to something. People can have ocular migraines for many different reasons. It could be a food allergy. It could be hormonal. It could be a light, or I've actually had someone have a smell, like there was a certain smell that caused her to have ocular migraines. But it's essentially some input, and we have to kind of figure out what that input is, some input that's triggering the system, and so then you get that migraine. Yeah, what's your second question?
EMDR. I just learned about EMDR. Eye movement desensitization, reprocessing,
Yeah,
or reprogramming.
yeah.
Is this a part of this topic?
What I do, yeah.
Out of bounds.
The question was EMDR, if it has any association with what we do. EMDR is more, so no. But I've had,
It's more what?
it's not related to what we do, but I have referred patients for that. So, and don't quote me because I don't know too much about it, but I co-manage a lot of some patients with neuropsych, and they do a lot of that testing and that type of therapy.
Can I talk to you after?
For sure. Absolutely. Hi.
Thank you for this fascinating talk and fascinating topic. Wanted to ask you a little bit more about the therapeutic prism.
Yeah.
Because, I mean, the fact that you can modify the environment and have the brain literally rewire.
Yeah.
Talking about the neuroplasticity, the
Yeah.
ability of the brain to actually heal itself. Wanted to know what that process looks like. Like, is it a 6-week process through which you modify the prism every week? Like, can you walk me through that therapeutic process?
Right. So essentially when I always watch my patients walk in the office, so I don't have someone else get them from the waiting room and bring them to my exam room. I always bring them myself so I can see them walk and I have a few turns. So how do they navigate that space? And then once I kind of figure out, we talk about their symptoms and stuff, and I figure out what I want to prescribe, I make them do things that make them feel bad, and then I put my lenses on to make sure I'm on the right track. But essentially, once I prescribe my prism, I grind it into if they have insurance or they have someone that they get their glasses for, I just write a prescription, and they get their glasses made, and then I'll schedule a 1-month follow-up. So they do have to wear the glasses most, if not all the time, for that full month. And then they come back and then we talk about everything and I rerun all my tests and I see, okay, what has changed, what's not changed. I get their subjective response, what's improved, what's not improved. And if I feel like, okay, you know what, you're on a good trajectory, let's just wait another 2 months. Or, no, this is not working, we need to reevaluate. And so I wait for that 30 days because it gives it enough time to know if we're making progress or not.
And typically, to see those therapeutic results, you said you graduate them out of it, right?
Yeah.
There'll be a point where they actually don't need it.
Yeah, that process takes a while. That's anywhere from 10 to 14 months. It all depends on the person. But the point, like I still have my prisms. So I still have a pair when I get really tired or I want to read something and like I just can't seem to get it done efficiently. I put my reading glasses on that have a little bit of prism to help my eyes work better together. And so, yeah, I mean, ideally it would be nice to have everybody get to a point where they don't rely on prisms. You'll maybe need prescription glasses, but not prism glasses. But if you have to, you know, you're having a sick day, you're really weak, or something's a little overwhelming in your life and you're feeling a little stressed out, like that all impacts how your visual system holds itself together. And so, yeah, it's not a bad thing to wear prisms either. So.
I grew up with debilitating migraines.
Yes.
You know, I had to get into silence, dark,
Yeah.
just to control them.
Yeah.
But it, and then years and years, and now I don't get them at all. I don't get headaches lately, and I go.
What a blessing.
I said, it's great.
Yeah. So you're asking me? Would have put me on the spot. I'm just joking. So just like why that could happen? Oh. So, I mean, so many different reasons it could. Oh, sorry. The question was that he grew up, he had debilitating migraines as a kid or young adult?
Sorry?
Did you say you had debilitating migraines as a child or as a young adult? Child, young adult. And then over time, they just went away. So he does not hasn't had a headache so that's really great. But I don't have an answer to that because there's so many, like, you know, the pressure in your head changes as you get older as well. That's one. You could also, it could be a biochemical, like a hormonal thing. It's probably not visual at that point, so maybe. Yes, sir.
I didn't hear the question about insurance. Do you take insurance like VSP, Visual Service Plan?
Yeah, so I don't specifically take VSP, but what we do is we write up something called a super bill, which is like a medical receipt for you guys to submit to your insurance. And then most of my patients have gotten reimbursed that way, through vision, not through medical. So medical, 2025, we're still trying to figure it out. Vision has been a little bit more successful in 2025.
I talked about I had the cataract.
Yeah, monovision.
Reading and distance.
Yeah.
And then I tried to get bifocals with prisms. I've gone several times to UC, and I only see double. So, and the doctor said, well, you're okay without the bifocals, just don't get the bifocals.
Oh, so you see double up close
No, when I'm looking at distance.
with the bifocal on?
Yeah.
Oh, with the prism?
Yes.
Let's talk about that after. If you have some numbers, I can actually look at it for you. Yeah.
Can the physics involved in making progressive corrective lenses be responsible for having depth perception and visual placement?
Yeah.
Particularly like going downstairs.
Yeah. Can you say that first part of the question again, please?
And the physics involved in making progressive
Oh.
corrective lenses.
Yeah. So the question, yeah. So the question is, do like the optical illusion of progressives affect how you judge space, like going down the stairs and things like that? And absolutely, yeah. Progressives, if I have a patient that is experiencing any kind of disorientation, dizziness, I do not put them in progressives for a while. I'm not saying never. I think progressives are a phenomenal everyday kind of pair of glasses, but I don't think during certain times it's not the right way to go because it affects your ability to judge space and it's not safe. And so,
I mean, it's not that fine as long as I'm really
like tucked in, yeah.
and check my posture before I go downstairs.
Yeah.
So I'm signing prisms now.
Okay.
If I get cataract surgery done, what's going to happen?
Yeah.
Are they going to put prisms in the cataracts, or I can't keep my glasses after cataract surgery?
That's a good question. So his question was that he currently has prisms in his glasses, and if he gets cataract surgery, what does that look like afterwards? So they will they're not able to put prism into the lens when you get that replaced. But essentially, I've had multiple patients where they do need cataract surgery, and so they'll be one way before surgery, and we don't know what it's going to turn out to be. Your visual system can change throughout surgery, so we essentially reassess afterwards. But most likely, if you're wearing prisms now and they support you really well, then you'll wear glasses on top after you get your cataract surgery. I know. The one downside about prism, there is one doctor in Scottsdale, Arizona that I met a bunch of years ago, and she has figured out how to put prism in hard contacts. And they're called scleral lenses. They're kind of the size of a quarter, so they're very large, but they go into your eye, and they do have prism in them. And that's been pretty successful for her and stuff. And I've, but there's only one of her. So I have sent her a couple people too, and been like, okay, if you don't want to wear glasses, if this is like a no-go for you, but they help you, if you want to fly out there, go for it. So I know that's one bad thing about prism.
Do you see kids with autism? I have 4-year-old
Yeah.
grandson, and the eyes aren't aligned.
Yeah.
He's got hearing loss that's neurological, and so yeah, you do.
Yeah. Yeah. So the question was autism, and if I see children with autism, but talking about that for a second, autism is a processing thing, and so again, the visual, vestibular, and proprioceptive are the three biggest categories of information that are being sent to the brain. And so if we have a misalignment or a misunderstanding of space, then that's going to change how the child is able to move through space or read or make eye contact or, whatever. So, yes.
Vision therapy or
Vision, I don't jump to vision therapy yet. It all depends on their function. So we don't want to create a stressful situation for them. So I actually have an OT on my team that does a lot of my children that are not able to sit and do traditional vision therapy. It's more play-based. Yeah. Yes. Oh, do you have another number for me? Sorry. No. Okay. Perfect.
Personal question in terms of the progressive advancement of prism strength.
Okay.
Because I've had, back when I was 14, an eye that was straight out, but I couldn't pull it back.
Okay.
So only about 10 years ago, the doctor noticed and starts putting prism in, thinking it would get better corrective vision.
Okay.
Well, every time we go in,
It's changing.
it's increased. It's increased. And finally said, well, should I be doing some exercises to get rid of these prisms? And oh no, balance. And it was like, oh my God, sorry.
Yeah. Yeah.
I mean, is this something that's just fine to you use sounds like compensatory prism.
Compensatory prism. Yeah. So.
Is that a concern that one's having each year?
Unfortunately, it's a little bit multifactorial because just like we lose our elasticity in our skin as time goes forward, we also lose muscle tone as time goes forward. So we're kind of at the same time we're going parallel, right? So you may be changing not because the prism is doing it, but also just because of your eyes are losing. There's like no way I could have said that another way. So.
Is that sort of thing in the ballpark of your wheelhouse? Or
Yeah. So in those cases, sometimes what we've done is we've done a short, just 5 to 7 weeks of therapy to see if we're able to help you with.
Stem the progression of.
Yeah, just kind of like just like you do PT and you have knee surgery, you kind of just do maintenance. So just like hold things together for a little bit, and then we'll watch you every 4, 5, 6 months. But I don't think. The reason you get that kind of reaction from other professionals about vision therapy, it's not like they're not poo-poo. Well, some of them poo-poo on us, but it's just because it's coming from a complete different training background, right? It's technically not their fault. It's just a matter of, do they want to dig a little bit deeper to help get you?
Google or something too.
Yeah, yeah, so, okay, yeah.
I just wanted to let you know, I'm a big fan of vision therapy. My daughter had it, which
Yeah, I heard.
she had the whole depth perception where she was looking behind words and in front of words and never really tracked people right very well.
Yeah.
Vision therapy was exactly physical therapy for the eye. We were on board. She had a home program that she would do.
Yep.
All the exercises. Come to find out, my husband, as an adult, was never a reader. Would never read recreationally. Through this process, found out, oh, I have what she has.
Yeah.
We all pass out our best genes, right?
Yeah.
So then he started doing the exercises, and lo and behold, he found out. And my question for you is, with the vision therapy exercises and the exercises at home, are you seeing progress in the adult population, like
Yeah.
in the pediatric population?
Yeah, yes, definitely. A lot more dependable results in the pediatric population. A lot more like I can be very clear and black and white about that and be like, if you do this, we're going to be gay. Like it's going to be awesome. With the adult population, it's a little different in the sense of I can't guarantee like, okay, if we do this, we're going to get this kind of result. And so that's a little disappointing for some people to hear as well. Adults are also very much more symptomatic. And so by doing a little bit of therapy, and that's why we actually have to be a lot more sensitive with our adults than we are with our kids. Like our kids, we can really push them and allow them to feel the discomfort. With adults, we have to like really tiptoe around it because we can throw them into some sort of, whether it's a vertigo spell or something, or a migraine or nausea or something. So it's different with adults, but I do stand by the adults that we have in our program, and we have, our clinic has become pretty much 50-50, 50% adult brain injury and dizziness, and then 50% pediatrics, learning, developmental. And the adults that are with us, they do make gains. Expectations are huge. So I always, in my office I'm with the family, I don't just talk to the patient, I talk to the spouse, the kids, whoever brings them, like they have this expectation, they want to drive. Okay, well, let's talk about the family's expectation. Do you guys feel comfortable with them driving? You know, like, what is that like? And so, but yeah, so. Yes.
Do you enjoy your work?
I love my job.
You opened the door on this, the old age diagnosis. When does one, in your field, give that diagnosis? You've gone through the ENT, you've done all the other exams, eye exams, et cetera, et cetera. Is there not a time at not a particular age, but advanced age that you can say, we've done everything, we can't find it? Is that appropriate, a diagnosis of old age?
That's a good question.
Yeah.
Did everybody hear that? Okay. So when is it in our, like in what I do, when is it appropriate to use the diagnosis of old age? I don't think I use the word old age because I don't think it's age related. I think it's the ability for the brain to heal. And Brigit and I are co-managing a patient right now, and she's got a lot of stressors in her life. She's got really bad symptoms, but she's got a lot of stress of taking care of her spouse and herself and just life. And so we both actually feel that the reason she has not made is not because of her age. I think she's a fighter, if anything, but I don't think it's her age at all. I think it's she's not sleeping, she's not healing, she's constantly stressed, she's not eating properly. So I think those life things, the amount of things that are on your brain and how you're compensating with all of that is what's the conversation, not so much age. Diet's another thing. Like, how much are we eating? I know sometimes we get on a lot of supplements, but like, what are we eating? How much are you sleeping?
But if you find there were the problems that you discussed there in its advanced stage, are you not able to make that diagnosis? I'm sorry. Forgive me.
No, you're okay. I always feel like we can do something. It's just a matter, I always feel like we can do something. It's just a matter of expectations and a matter of what are you willing to do? Like I've had a lot of people that also come to me, I'm like, okay, you know, work with your OT, I want you to work on these 5 things. And then they don't do it at home. Okay, well, how much results are we gonna get if you, so I mean, so I know, very rarely I chalk up to old age.
What would be something you know, we have our iPhone, we have our TV. What do you think are things maybe people could do on a regular basis to help prevent maybe a brain crisis, if you will?
Oh, yeah.
Have a mild stroke or have a mild event. What are things we do things that we tell our patients like, you know, you really need to work on your flexibility over time and not wait till it becomes so tight that now you have a problem. You need to work on your strength over time.
Yep.
So now you're not working from ground zero. What
Yep.
do you think are some safe vision exercises that everybody should be doing, maybe to prevent like always being so locked into their screens?
Yeah.
I feel that a lot of people are so tunnel vision because of this.
Yeah.
That they don't process the world.
Right.
So just didn't know if you thought about
Yeah, so, yeah, thank you for that. So vision related, I would say a lot of like just going back from near far, you know, so whether it's read a paragraph of your book and then look away out the window and then come back, I mean, that's the biggest. Tracking and stuff, you know, tracking is an issue for some of my patients. They do say, okay, when I like to read, but I can't really, that's a little bit more, we can fine tune that, but just on a day-to-day, just keep that flexibility on that Z-axis, keep going back and forth. But one of the things that I talk to the most in our clinic is sleep. I actually promote a lot of, well, not promote, but I talk a lot about like meditation and like let's, you know, calm the system down a little bit. So sleep and also high-dose fish oils is something that we talk about a lot. So about 2,000 milligrams of fish oils. Again, clear it with your primary care, make sure that you don't have any other things going on. But I talk about that a lot. That's really important for your brain. Your brain likes fat, so. Any other questions?
We're gonna, how about this? We're gonna, if you guys would like to go talk to Dr. Nathu personally, we'll let you guys do that, but some of you might have to head out the road, so we're gonna give her a round of applause.
Thank you so much.